thank you very much for the very kind invitation to be here at this very interesting conference on personalized medicine and resource allocation. So I'm not going to talk about challenges. Maybe just at the very end of my talk, I will have one slide with some more challenges for you to think about. What I would like to do is to come up with some of the work that has been published before and that James and Jill just presented here in the previous presentation. But I've taken this kind of paper in Value and Health, special issue on personalized medicine last year by Lieven Annemans and Catherine Payne and Ken Redderkop, a Dutch colleague of mine, listing 10 challenges. And among those 10 challenges for health economic modeling in personalized medicine, there's one thing that really got my attention. That's the need for early modeling. So that's actually the title of my talk today, early modeling. And to continue with it, I think we should first define what do we mean with early modeling. Early modeling clearly is not about waking up very early, starting the modeling right away, although it was very early this morning for me, coming over here. Now, early modeling, it really depends on who asks that question. If you ask about early modeling to HTA agencies, they will say, okay, we do modeling in phase 1 to clinical trials. So come up with this very interesting paper in 2009 in the International Journal of Technology Assessment and Healthcare. And they reviewed quite a few, nearly 1,100 cases, HTA reports on the stage of the assessment. As you see, most of the assessment reports were submitted to the HTA agencies in phase 3, particularly for drugs, phase 3. Then you see interesting difference. If you look at the devices and diagnostics, most of the reports or most of the HTA value dossiers are being prepared just after phase 3 trials, after the device has been implemented in healthcare. So if you talk about HTA agencies about HTA early modeling, they would say, okay, we should start right away with the modeling. We should move this late stage modeling to earlier stages, even for devices and drugs, or and diagnostics. But I've taken a different look. I'm actually based in a technical university within a Biomedical Engineering Institute. And the questions that we have been asked by our colleagues, engineers, say, can you support us with making appropriate recommendations about technology development based on your health economics expertise? So we would go even before phase 1 modeling. We would even go here, say, can we identify potential applications being developed at the moment? And can we support that development by informing them about health economic considerations? So even before stage 1. And I would say this is what I would say early health economic modeling. And this is in line with what has been written before by Jan Pitsch also in the International Journal of Technology Assessment, where he compared classical HTA to early HTA. So, well, the main aim of classical HTA is to inform policies, to inform safety, efficacy, cost effectiveness, to inform decisions by regulatory agencies, by reimbursement agencies. Whereas in early HTA, this is about the likely efficacy, cost effectiveness of new technologies. And this is not to inform policy, this is to inform manufacturers or engineers or developers to fine-tune their development. That's a different kind of decision support. Obviously, developed evidence here, that's what we're talking about, is that comes from clinical trials. But in early HTA, if we move that far in the development pipeline, there's no evidence. There's just some data from bench testing, benchmark testing, or early clinical experience. And that we can use in our early health economic modeling. One big difference is that here it really has no impact on the technology performance. The technology has been developed, is being implemented, but here we try to influence technology development and technology performance. So we might be able to influence that performance and value produced to society. So if we take a wider look, and this is comes from a chapter which Wolf and myself and Jürgen John prepared for the World Book of Health Economics on translational health economics, we could see three distinct reasons for using health economic expertise in the translational research development pipeline. So first, we try to determine the value of a new technology, new medical product, to inform the initiation of the translation process. Should we continue with the development? That will be one first objective. The second, how can we evidence of an emerging health technology's value be established as early as possible during the translation process? And what type of information, what type of evidence is required to continue with that development? And finally, how can the translational value chain be optimized to overcome multiple barriers along the way to market access and reimbursement? So there's three distinct reasonable objectives for doing early modeling. So we did a survey, about 2,000 different papers were searched with the sub keywords about what different methods have been used, have been published about that do early health economic modeling or early assessments of medical devices. And for you, those of you who are interested, I can send you the paper, but just very quick conclusion is that there's two big categories of papers. Well, this is the biggest one, of course, but this is just engineering kind of papers that think about a potential application or write a paper about a potential application of a new technology. But when it comes to health economics and clinical and economic evidence, there's two categories of papers that are interesting for us. This is the health economic impact analysis. So can we do early health economic modeling to establish the health economic impact early on in the development stage? And the second thing, which appears quite often, is stakeholder perspective. So what do stakeholders think about this new technology development? For instance, patients about acceptance. So that's two big categories of papers being published. So I want to take you to one of the topics that we're working on in our university, which is on nano-oncology, so new emerging technology developments to detect cancer. So we've all been talking about profiling and NGS, but in the very end of the day, you have to have some tissue to do sequencing. So we have to figure out where do we get the tissue? Do we sequence primary tumor tissue? Do we sequence other sorts of tissue? So that's what we're talking about here. So there's different developments in early cancer detection. So one of the new emerging developments is the use of methylated DNA as an early sign of cancer. And you can detect hypermethylated DNA in urine to detect for bladder cancer, gastrointestinal tract for colorectal cancer, or for cervical cancer. So different applications of hypermethylated DNA as an early sign of cancer, of a malignancy. The other development that we're working on is liquid biopsies for prognosis and to evaluate the probability of distant metastases. And there's two, some would say competing technologies, which one is cell-free DNA fragments, and the other is circulating tumor cells. I don't think they're competing at all. They're quite different in terms of what information they provide. But circulating tumor cells, there's been quite some experience on that. And currently we know that CTC counts, if there's more than 5 circulating tumor cells that were detached from a primary tumor in the blood, in 7.5 milliliters of blood, they have a prognostic value for that patient. So we know it affects survival in breast cancer, colorectal cancer, and prostate cancer. So that's the evidence that's available. And this is a technology which is cleared by the FDA, cell search. This is commercially available by Veridex, Janssen Diagnostics. The problem with the cell search and the CTC detection is that although it has a prognostic value, the utility of that information in terms of actual clinical decision making is lacking. We don't know if it does influence treatment decisions in a good way. So we do know that the presence of CTCs in the peripheral blood is relatively low. It's only 1 per 10,000, 100,000 cells. And that means that if you isolate only 7.5 milliliters of blood, you only detect CTCs in half of the patients, so that lacks sensitivity here. So to increase the sensitivity and potentially the clinical utility of detecting circulating tumor cells, we have to sample at least 1 liter of fresh blood. And we have to develop technologies to extract those from the blood automatically, and also to profile those circulating tumor cells. And there's several projects going on in our department. European funded project on CTCtrap, for instance, is a project, but also recently the Cancer ID project that developed this kind of high sensitive CTC detection technologies for screening and for therapy decisions. So this simple starting point, because the question is in that work package is what's the health economic value? The simple starting point of early health economic modeling would be just to draw a decision tree with treatment A and with a probability of success, with a survival, and with a new potential treatment B with a target profile, target benefit. And of course, by changing that target, the probability of success of the new treatment, we can figure out if it produces health economic value and be cost effective to society. So that's a very simple, straightforward way to look at these technologies. But it's not that simple. If we take the technology perspective, we're developing a technology for circulating tumor cell extraction from the blood. We can use that for multiple purposes. So we have to model the care pathway. We can look at screening. We can use it potentially for screening. So if we start all the way here with screening, mammography, this is breast cancer, mammography, abnormality detected, biopsies performed, confirmation of malignancies. So here you could also use CTCs to see if there's a probability of distant metastasis, which would affect your treatment decision. Then there's a series of imaging technologies, and finally there's also a decision to monitor your therapy. So you prescribe therapy, chemotherapy, you can monitor response to that chemotherapy using CTCs. So there's different ways that you can use CTCs or advanced diagnostic information to monitor progress in those patients. It would be very hard to do economic modeling for all these different applications. One of the very simple approaches that we've taken in this first stage is to do headroom analysis. And in headroom analysis, we can help inform instrumental decisions concerning new treatments. So where do they produce most value to society without building a very complex model with wide parameters uncertainty. It's a very straightforward, simple approach. Where's the headroom? What produces most value to society? So we assume an incremental an effective gap. We assume that we are going to deliver value to society. We've assumed a willingness to pay, and then we can estimate the incremental costs. Below that, we should be in order to be cost effective to society. So there, in performing headroom calculations, there are potentially three options. You can look at the effectiveness component. So you can assume that the new technology is equivalent to the comparator. You can assume the device is X more effective, or you can take a very optimistic scenario that it restores perfect health, your new device. That's the three options that have been described. And in addition to that, headroom can also be supplemented by a rudimental analysis of cost to also try to estimate the price ranges to inform SMEs for further development and market access. So just in the figure, so this is the new treatment, or the old treatment. We expect the new device here will deliver quality gains or life years gain. So that's the value produced for society. And giving a prevailing willingness to pay threshold, this will be the headroom for the development. And this will be the expected incremental cost. And as far as we are below that headroom, there's room for improvement, or there's room for further development. So if we go back to that flowchart, the care pathway for breast cancer, we've identified 4 different uses of circulating tumor cells during the care pathway. For screening, for early staging, just after confirmation of malignancies, to guide adjuvant therapy, and finally to monitor progression. So that could be 4 options. And obviously, this is quite a few patients. It's based on the Netherlands figures, 17 million people. Further down the pathway, there's only less people that can benefit from this additional diagnostic. So what I would like to do very briefly is to focus on option 2 and 3. So can we use early stage CTC for early staging and for adjuvant therapy? And this is kind of one of the 2 difficult figures, but it's interesting to see, to understand what we're trying to model. So this is the primary tumor growth rate. There you go. Until at a certain moment you can detect that primary tumor with standard imaging. So that's the imaging detection limit here. At that time that this is visible on standard imaging, you see there's also, on the right axis here, there's probability of distant metastases. So this growth rate is going that steep, and at some point there's also a very high probability of a distant metastasis. What you can figure out from this figure is that the moment that you can detect your primary tumor with standard imaging, you will not be able to detect a primary metastasis, distant metastasis, which is present in real life. So if you only target your primary tumor, there still is an opportunity, a risk that there's a distant metastasis, which will affect survival anyway. If we try to use circulating tumor cells, we can change our detection limit. We can move it earlier in time. So this is the primary tumor growth, and this is the number of circulating tumor cells coming from the primary tumor. So you see that starts just after the start of the primary tumor growth. And if you want to move that detection somewhere before in time, earlier in time, you can also figure out the detection limit for the circulating tumor cells. So if you can, if you show that there's less than 9 circulating tumor cells per milliliter blood here, then you're pretty sure that there's no probability of a distant metastasis. So this figure depicts kind of the threshold for circulating tumor cells in order to include there's no high probability of distant metastasis. So these circulating tumor cells will provide an additional diagnostic tool to figure out if there are distant metastases, which will affect treatment decisions, of course. Because if, depending on the staging, if there's a highly aggressive tumor, the Dutch guidelines say we prescribe a very expensive drug treatment, aggressive, or if there's suspicion of metastasis, which may in the end result in overtreatment or undertreatment. Patients that have a sign of distant metastasis are probably being undertreated. So we can better optimize or personalize the treatment, chemotherapy treatment, based on that additional diagnostic information. The other thing that I'd like to share is the difference in expressions. So this is all individual patients, breast cancer patients, tested for HER2. The pink here means that that patient is HER2 positive. The other pink line here, that gives the HER2 positive patients based on the circulating tumor cells. So circulating tumor cells are determined in those patient groups, and there's 100% of them are HER2 positive. So we would say this is concordance. So in the primary tumor, this is HER2 positive, and in the metastasis is also HER2 positive. But you also see there's disconcordance in quite a few patients. So here there's 2 patients, and here's 3 patients that are HER2 negative in the primary tumor and HER2 positive in the circulating tumor cell. So here you could say, well, what do we target? Do we target the primary tumor, or do we target the circulating tumor cell and potentially the metastasis in our drug treatment? So this is disconcordance, and here's also disconcordance. Patients with HER2 positive primary tumors, very low probability of HER2 metastases. So this concordance is not new. It's been described previously in many tumor types. So if we take that disconcordance between primary tumors and the CTC tumors, you can see there's possible shift between the expressions. So this is a HER2 negative, hormone receptor negative, HER negative patient group, and in the CTC, in the end will be hormone receptor negative and HER2 positive. So there's disconcordance, and this is in all the patients. We know there's 14% of the patients are disconcordant in terms of HER2 for the primary tumor and HER2 plus for the circulating tumor cells. So that's the disconcordance rate. And if we have this kind of disconcordance, we should be able to switch therapy. So based on the primary tumor, we would have given chemotherapy, a cheaper one. But based on the HER2 positive expression for the circulating tumor cell, we would switch our therapy to Herceptin and chemotherapy. So the treatment will be more expensive in that patient group. In the end of the day, if you take all these discordance rates, in the end of the day, we can gain progression-free survival because we have a more personalized treatment, targeting both the metastases as well as the primary tumor, but with more costly to the patient, to society as well, because we switch most of them to a more expensive treatment. So to summarize, we did this Headroom analysis for the 4 different options: screening, early staging, late staging, and therapy monitoring. And I focus on these early staging and late staging. And clearly here, well, this is the total population that might benefit from it, based on the Netherlands figures. 33% of the patient might benefit from this early staging using the CTCs. And if we do that appropriately, we can have a more sophisticated staging and therapy decision, which will, in the end, will lead to quality gain. We have estimated that to be 1 at a cost of 12,000 euros. We'd add more cost to the system. But there's headroom for improvement, so it's 42,000 euros. Where in the third option, the late stage and the disconcordancies, there's a extra cost to the system. So we add the diagnostic information, and the result is that will be more expensive to the health system. So in terms of where do we focus our development, we would go to option 2, early staging, to have an additional tool to detect, to figure out if there's a probability of a distant metastases. Okay, well, this is to some extent it's complicated, but some of in the terms of health economics, it's quite a simple approach. Headroom is quite a simple approach, which can be more complicated. We've been talking about molecular profiling, and we only looked at 2 markers, HER2 and hormone receptor. There's many more that we can take into consideration, and particularly if we develop a technology to do sequencing in the CTCs, that gives you some more information. So it's going to get much more complicated if you do a proper analysis here. So I would like to, that's what I promised when I started, I would like to end with some extra challenges in the way we think about these early health economic models. So these early models, basically the models are becoming more complex. So we move from single sequencing to single treatments to arrays of mutations and multiple treatments, and even switching treatments. It's not just one drug, it's a combination of drugs or series of drugs that we can use. We can use biomarkers in different ways. We can use it to decide about appropriate treatment. So a single mutation, we prescribe one single drug. But we also can use it to monitor response and to switch therapy. That's some of the work that we currently do with prostate cancer, progressive prostate cancer, to switch from first, second to third line chemotherapy based on the CTC count or cell-free DNA. And that's even more complicated because that introduces time dependencies in your model. It introduces feedback loops. We probably cannot manage that with classic Markov models. And it will be increasingly complex to frame the decision problem because we are not targeting tumors specific. We're targeting molecular mechanisms in our drug treatment. There is evidence of disconcordance between the primary tumors and the metastasis. So what are we targeting in the end of the day? There's even evidence of variations in mutations over time. HER2 positive might be different in 2 years. So how do we handle that kind of variation in time? Also in particular to prescribing therapy. So I think we might end up at the end of the day with some other modeling approaches that really are able to capture those dynamics and those interactions between professionals and the health systems, like systems dynamics or agent-based modeling. Thank you very much for your attention.